Good morning, everybody, and welcome to Georgia Heart Grand Rounds. Thank you all for joining us today. This program is brought to you by Georgia Heart Institute. The planners and speaker have disclosed no relevant financial relationships with commercial interests. Please scan the QR code to sign in for attendance. Please also remember to take the evaluation at the end of the program, which will be shared with you at the conclusion of the talk today. If you are virtual, the links will be dropped into the chat. And now it is my pleasure to invite Dr. Eglum up to the stage to introduce our guest speaker today.
Awesome. Good morning, everyone. Very excited and happy to introduce our guest speaker today. I was just joking with her a second ago that I'm not sure how she had all this time to do all this training, but it's quite impressive. So Dr. Afshan Hameed is a maternal fetal medicine specialist and a cardiologist as well at the University of California, Irvine. She's board certified in internal medicine, cardiology, OBGYN, and maternal fetal medicine. She's actively engaged at a national level to improve maternal mortality and morbidity, particularly within the space of cardiovascular disease. She served on the California Maternal Quality Care Collaborative and has been involved in the Pregnancy-Associated Mortality Review Advisory Committee since 2006. She was instrumental in creating the Cardiovascular Disease and Pregnancy Toolkit and also chaired the AIM Cardiac Conditions in Obstetric Care and Patient Safety Bundle. So quite a lot of work within this space over a number of years. She's also NIH funded and studies cardiovascular disease risk assessment and pregnancy. If you look her up, you'll see many publications in the field that she's co-authored and also co-authored a textbook entitled Cardio-Obstetrics, a practical guide to care for pregnant cardiac patients. On a personal note, she's a mother of triplets, daughters. Wow, impressive. All right, well, we're excited to have you and we're looking forward to discussion. Thank you.
Thank you so much. Thank you. Good morning. Thank you for the kind introduction. Thank you for having me here today. And yes, I am crazy because I was a cardiology fellow, got interested in pregnancy-related cardiovascular disease back when. And at the time, there was a big gap between cardiology and OBGYN, and it's inspiring and so motivating the work that is being done in the space of cardio-obstetrics, where the cardiology and OBGYNs have come together, and there's a lot of national initiatives, and particularly Georgia. I'm so proud of Georgia, the work that you all are doing in bridging this gap. With that, we are going to talk about maternal mortality and is cardiovascular disease related deaths preventable? I do acknowledge the funding source of the work that we have done. There are 4 areas we're going to touch upon. The background, why are we here? How did it get started? Why is cardiovascular disease not recognized? How can we improve? And how do we put together a cardio-obstetrics team? Is it even required or needed? Most of you are aware of the maternal mortality crisis in the United States. And we have been doing a lot of work in the last 20 years. And that has stabilized or gotten a little bit better. But more recently, you must have seen this graph where the maternal mortality rates were significantly higher in 2020. And then 2021 was even higher, up to 32.9 per 100,000 live births. However, after that, in the last year or two, they have stabilized. Nonetheless, we need to figure out where is this mortality coming from. When we look at the pregnancy, I'll take you back to California, because California, again, is a big state, it's interesting to share that 1 in 10 babies that are born in the United States is in California. So 1 in 10 babies, a lot of maternity care, obstetric care in the state of California, sometimes, it dictates or it helps a lot with obstetrical care in the rest of the country. So these particular data, as you see here, that cardiomyopathy and cardiovascular disease, if you combine both of them, 29% of mothers who die is due to cardiovascular disease. That's why we are here. We are here at the Georgia Heart Institute because of the link of maternal mortality to cardiovascular disease. There are 4 things I would like to you to take away from this. One, we know that cardiovascular disease is the #1 cause of maternal mortality. Number 2, there are racial disparities. Black mothers, much higher risk of maternal mortality when compared to white or Hispanic mothers. Number 2, when we look at the age distribution in these segments of 2018, 19, 20, and 21, in these 4 bar graphs, under 25 years of age, 25 to 39, and 40 and over, the take-home message is the older the age, the higher risk of maternal mortality. And a very important piece that when it comes to maternal mortality is, when is this happening? So if we distribute that into 4 areas, while pregnant, which is the darkest blue, 0 to 6 days after delivery, 7 to 42 days, which is the conventional postpartum period, first 6 to 8 weeks after delivery, and then beyond that postpartum period, which is when a woman delivers, they've finished their prenatal care and up to a year after delivery. So they're not necessarily under care of the obstetrician at that point. And as you note here, when it comes to cardiovascular disease, only 16% maternal mortality is during pregnancy. In the immediate postpartum period, within a week after delivery, is 30%, 22% in the postpartum, conventional postpartum period, and 32% is beyond. This is when the patient is out of the OBGYN care, and and a patient may present to their primary care or to ED or to other health services for care. And this goes, and now I'm going to take you back because we are talking about the cardiovascular toolkit. We are talking about how to screen patients with cardiovascular disease. I'll take you back to this work when it got started in California. We are looking at the timing of diagnosis of cardiovascular disease and death. And it was really humbling to see that out of the 64 deaths, only 2 mothers who died had a diagnosis of cardiovascular disease when they entered pregnancy. 62 had no clue that they had cardiovascular disease. And then 48%, this piece here, 48% of the cardiovascular diagnosis was made at autopsy. So the mothers had died. At autopsy, the heart was very dilated, whether it was cardiomyopathy or was it a congenital heart disease that was completely unrecognized all through the woman's life. So those are the important points when we look at the cardiovascular disease, that this may occur beyond, and we are not picking it up soon enough. So this brings us to the next question. We know that cardiovascular disease is not recognized, but why is that? And the reason being that there are so many hemodynamic changes in pregnancy that mimic cardiovascular disease. We know that the plasma volume goes up, cardiac output goes up, the stroke volume goes up, heart rate is higher. Very commonly, patients have shortness of breath, they are tired, they have lower extremity edema, JVD may be a little bit higher because of the volume overload. So there's so much overlap with the signs and symptoms of normal pregnancy with cardiovascular disease that it becomes a bit of a challenge to dissect it out. And another important point from this slide is that we usually think of pregnancy when the patient is 3rd trimester or 2nd trimester, but these physiologic changes are literally at 12 weeks of pregnancy, at 20 weeks of pregnancy, when they kind of are getting to the max. So even if the patient is 18 or 20 weeks, and they're symptomatic, it could be because of cardiovascular. And the most common time when they become symptomatic with pre-existing cardiovascular disease is going to be around that time, 24 to 28 weeks. And this is what I tell the patients, that these cardiovascular changes are geared to improve the perfusion or perfuse the placenta and the fetus and have a healthy pregnancy outcome, because the baby needs all of this extra perfusion for various reasons. And it's being on the treadmill for 9 months. So when I'm doing a preconception consultation for a pre-existing cardiovascular disease, patients may not be symptomatic, but when you put them on the treadmill, yes, they are, and you may decide whether they should or should not be pregnant and have a conversation with them. So a good concept to keep in mind. Again, going back to the work, the initial work from California, how did these patients who died present? They actually presented with conventional symptoms that you would see in your cardiovascular practice: shortness of breath, palpitations, edema, chest pain, dizziness, extreme fatigue. And most of these symptoms were actually seen in the postpartum period. They also had prenatal and labor and delivery at the time of labor and delivery, but most in the postpartum period. And that has to do with the cardiomyopathy that may occur in pregnancy or postpartum period. And they also had abnormal physical examination findings. So when we were reviewing these charts back when, so we had this whole stack of charts from their admissions from ED to any hospital, any outpatient. The common things we actually had, they had documented blood pressures of 140/90 or above. They were tachycardia 120 or above. They were crackles. They were documented in the medical records, and O2 sats were low, but nobody ever thought about cardiovascular disease. Nobody thought about a diagnosis or a further testing that this patient may need. And the most humbling experience from review of maternal mortality was a common theme. This was a patient who presented to the ED or to their provider with symptoms, with shortness of breath or extreme fatigue. Not once, not twice, but more. They were seen in the emergency room, and they were sent out with a diagnosis of new onset asthma. They were sent out with antibiotics. These patients had presented again in a week with the same complaints and not improving their symptoms. They were sent out again. And then the third time, it was too late. So we determined that the contributors to maternal mortality was both providers and patients. Most of the providers did not think. Diagnosis was delayed, treatment was not given, misdiagnosis, no consultation, and likewise patients didn't know. And you can see that about 70% of the times was the contributing factor. And this was the quality improvement opportunity for us. And we are here today, all of you who have been here, who have joined this at 7 o'clock in the morning, early morning, because we are here to bridge this gap. We want to know, what can we do so mothers don't die of cardiovascular disease in future? When I'm talking to the obstetric colleagues, it gets daunting when I talk about, the cardiovascular disease and how to diagnose and what are the different diagnoses and how do I know? A very simple way to put is, no matter what type of cardiovascular disease exists in an individual, the bottom line is going to be they either present with heart failure or arrhythmia. If you don't recognize it, don't treat it, they go into this spiral of death. And particularly in pregnant patients, because they are the lowest on the radar in terms of having cardiovascular disease. Why is it important? because it's a high mortality, racial disparities. 1 out of 3 deaths are preventable if you diagnose it earlier. And it's a silent killer because pregnancy mimics cardiovascular disease. So the next question is how to improve? What can we do? And really, the bottom line is we have to recognize to treat. And we all know that the number one type of cardiovascular disease that exists in a reproductive age people is congenital heart disease. And we also know that when we review maternal mortality, only a fraction, 2% or 3%, is due to congenital heart disease. It means that when we know that a person has cardiovascular and they are pregnant, we treat them appropriately. We follow them so they don't have bad outcomes. Whereas the problem exists in patients where we don't know they have cardiovascular disease. They're having symptoms, whether this is an underlying condition that they don't know of, or it's a de novo cardiomyopathy, as you're aware of peripartum cardiomyopathy, that can occur in otherwise healthy pregnant postpartum patients. And nobody really knows 100% why it occurs except for the hypothesis that exists right now of the abnormal form of prolactin being apoptotic to the cardiomyocytes, and the role of bromocriptine and the work that is being done in the US with the Rebirth trial will get more answers in a definitive manner. But it's getting to that point. How do we know the patients have? So we developed this toolkit, and there are 2 algorithms that I'm going to show. And when we applied these algorithms to the maternal mortality or the 64 cardiovascular deaths by 2 independent reviewers, 93% of these patients would have been picked up as high risk for cardiovascular disease. And like I said earlier, these were patients who nobody thought of cardiovascular, so they didn't get the appropriate treatment. And these are the 2 algorithms. The first one is the red flags. These are patients who absolutely right now need further care. These are patients who are severely symptomatic, severe vital sign abnormalities, or these are patients who have a known diagnosis or personal history of cardiovascular disease. All of these patients need to be followed when they are pregnant. Even if it's a simple VSD that they think, or they tell you that there was a hole that was closed and they've been fine, but we all know that all VSDs are not equal. This could be associated with pulmonary hypertension and so on. So that was pretty clear to us. We said, okay, so these are the red flags, these patients who are presenting with severe symptoms. But what about all comers? Because we know that peripartum cardiomyopathy, and cardiomyopathy is one large portion of cardiovascular related deaths. So we created this algorithm for all comers, which is 4-bucket model. Anybody with abnormal physical examination findings, whether they have a loud murmur or basilar crackles, they need to be evaluated further. Or if there's a combination of symptoms, abnormal vital signs, and risk factors, these patients also need to be evaluated. So now the question is, what do you do next? What type of testing? And this is up to the center you are at, up to the resources at that particular place. It could start off with a simple EKG and a BNP level. Depending on the symptoms, you may or may not decide to do an echocardiogram. But the bottom line is just recognizing if the patient is at high risk, letting them know, and having it in her problem list or as a reminder if she comes back with further symptoms. What we have done is integrated this cardiovascular algorithm into our EMR, which is EPIC. And it's very simple. I'll share some slides. It gives you a risk assessment, whether the patient is low risk or high risk. And patients who are high risk are given appointments for further testing and follow-up. So this is one of the screenshots from our EPIC workflow. With a pregnancy episode, usually we have a tab up there that is OB tab. If you open it, The sub-tab is cardiovascular risk. You click on that and you get to this CVD risk assessment. These are all 18 elements that are part of the algorithm. And I don't want to get necessarily stuck on those 18 elements and the complicated, number of these elements. And this is exactly what we are doing with our NIH grant. We are almost, we are in the data analysis phase. What we want to do is to see out of these 18 elements, which ones are more predictive and which ones can be dropped off. And so that we can make it better and more feasible to do down the road. But the way it exists, all you do is when you click this button, pull data from chart, all of the vital signs, risk factors, all of this history comes here. And if the patient is not self-reporting or coming in saying that I'm having chest pain, we just mark all symptoms negative. And then if there's any physical examination finding, we put yes or no. Just by doing that, it'll auto-populate with the extra stuff, and it'll put you or give you a risk assessment, not at risk. And then if, for example, this patient had oxygen saturation that was less than 96%, had a murmur or other things, this patient would be at risk for cardiovascular disease. When they are at risk, this big red flag comes up on the right-hand side. Follow-up required, and these are smart forms that are built into the EMR, so you click whatever test you need to do, and that takes care of that particular patient in terms of screen follow-up. Now, our partners in Tennessee at University of Tennessee and St. Thomas system here, they are using Cerner. So they built this into the Cerner, and they have screened thousands of patients, the data that we are going to be publishing soon. And it's a little bit different. They have these 3 buckets there, and you individually click into the boxes. And then the next screen is a maternal risk screen, positive or negative. What they do in their patients is, if the patient is screen positive, they give them a little credit card size card that has a big red heart on it, and it says, I am at increased risk for cardiovascular disease. So this patient carries in pregnancy, postpartum, and they know if they come in with shortness of breath or other symptoms to be on a watch out for. So it gives that educational piece to the patient. So this particular algorithm, the 4-bucket model that I shared with you earlier, we started out before we built it into the EMR by partnering with our colleagues in New York because they have a large Black population. And we published this 4 years ago, 846 patients. At the time, it was a paper checkbox, 18 elements that residents and fellows and nurses were helping fill out for each patient. And we saw that the screen positive rate overall was 8%, 5% in California, 19% in New York. There were a lot of patients who didn't show up for their testing, but in general, who followed up for testing in the screen positive patients, about 30% had some form of cardiovascular disease. And that ranged anywhere from a patient diagnosed with a VSD that she didn't know of, to hypertrophic, to cardiomyopathy and stuff. Not a cardiomyopathy, but a little bit of left ventricular hypertrophy or mild systolic dysfunction and stuff. So there were a significant number of patients who required use of medications or change in their plan because of cardiovascular screening. So this brings us 2 years later. This was in 2022, and you're all aware of Alliance for Innovation on Maternal Health, A.C.O.G, the initiative where there are bundles. There are clinical bundles for implementation in various areas. So they convened a team of cardiologists, MFM, OBGYNs, emergency room, anesthesia, nursing, midwives, to put together this cardiac conditions in obstetrical care bundle. And this was along the same guidance in other bundles, from readiness to recognition prevention, the response, reporting, and respectful care. It was published last year. And I will just highlight a couple of things. One, in readiness, which means every clinical setting where a pregnant patient may come. Implementation of cardiovascular screening was a recommendation. At the time, the only algorithm that has been validated to some degree is the CMQCC algorithm that I shared with you. They recommended that or any other form of cardiovascular screening for all clinical settings, and also for prevention and recognition piece to have a standardized cardiovascular risk assessment for pregnant and postpartum patients. So this work that we started, screening of cardiovascular disease, that was the first step. The next step is to get it to be standardized as a quote unquote measure, a quality measure through CMS, through the national agencies, for it to be the standard of care for pregnant and postpartum patients. So as part of this work, the first thing that we did is to look at the feasibility in 3 hospital systems, whether cardiovascular risk assessment is doable and how many patients actually get a follow-up. And these are data from about 15,000 patients, 3 hospital networks. And the only important thing that I want to highlight is the percentage of patients who get screened at these 3 hospital systems is very different, from 57% to 98%. And this hospital 3 is actually Tennessee, where they have a hard stop in their EMR. Any patient who is pregnant, you can't go to the next screen until you screen the patient. So the screening rate is 100%, almost 100%, but then their follow-up rate was not as great, about 55%. So it depends on how this cardiovascular screening takes place and how is access to medical care. So there's a lot of barriers that we identified, from insurance to access to care and the health literacy and all of those things going through this study. So the cardiovascular risk assessment in pregnancy was presented to CMS as part of their MIPS program, the merit-based incentive payment system, and it was unanimously approved for use in Medicare patients. Because we don't have data from Medicaid population to get to that evidence point where we could say that we can actually implement it. So that's where collaborations with other states and other institutions at a higher level, where there's a large population, large Medicaid population, where this screening is done, for it to go to the next step of becoming the standard of care. And this is a journey from cardiovascular tool development in 2017 to our grants, to implementation and dissemination. Last year was the first time where we actually had all of the outcomes, data, and reporting. So the next step for us is to go to the PQM, which is a partnership for quality measures. We had submitted it last cycle. It was not approved because we are lacking data on the Medicaid population. So that's where the partnerships come in, and we have gathered more, and we are resubmitting it for it to be the standard of care, because that will be the only way to identify patients who are at risk for cardiovascular and treat them. So as I see it, there are 3 benefits. Not only you identify the high-risk patients who require further testing, follow-up, but it also improves patient and provider education and awareness. A lot of these patients, like I mentioned earlier, they are presented to them beyond their conventional postpartum period to an emergency room. And we are not aware that this actually exists. The cardiomyopathy may happen up to 5 months after delivery, and they may present even though they were completely fine during delivery, postpartum period, but the first time they may have heart failure 3 months after delivery. So a basic question of were you pregnant in the last year, may help identify those patients. And of course, on a longer term, it gives you an opportunity to modify the risk factors. Because as you saw in the risk factor category that we have, these are patients who are hypertensive, diabetic, or have other risk factors. It also helps to transition to primary care and preconception care, postpartum risk evaluation, and prepare them better for next pregnancy. And we all know that cardiovascular risk during pregnancy translates into cardiovascular disease risk after pregnancy throughout the woman's life. So we still have to learn more. We have to learn about the risk assessment and how to link those risk assessments to abnormal diagnostic testing, EKG and echocardiograms. So we are working on those testing as an intermediate measure to assess the positive predictive value of testing. And then we need future long-term studies to evaluate the benefits of obstetric CVD risk assessment. How does it translate to the differential outcomes 10 and 20 years from now? So longer term studies will be needed down the road. And we believe that there should be universal cardiovascular risk assessment in pregnancy. Again, we did this work with utilizing the algorithm that we have. I know Georgia has another one, which is great. It could be any type of cardiovascular screening. The bottom line is how well does that screening tool perform, and then come up with collaborations in a way that we collect and analyze data from all the different groups that are doing this work and come up with one standardized version, which is simple and feasible and not only applicable in academic settings, but also in community and remote settings as well. So the last piece that I wanted to talk to you about is the Cardio-Obstetrics Team. And whenever there's any initiative, of course, first of all, do we need it? Is there interest and passion? Do we have cardiologists who really want to do this? Do we have obstetricians and nurses and anesthesiologists who would be part of this initiative? And do we have the support and resources that we need? And that will need to be gauged at an individual facility level, at your unit. What is that level of interest? And then really the goals are twofold, not only for the risk assessment piece that I talked about, that is more preventive and capturing patients who don't have a diagnosis of cardiovascular disease, but also patients who have underlying cardiovascular disease. And we always want to risk stratify them. So clinical evaluation in a multidisciplinary way, the risk stratification, and moreover, the management plan through the pregnancy and postpartum period. And how do these patients get follow-up? So, every institution have their own way of following these patients, but what we have a dot phrase in our EMR, and any patient who is cardiac, you put the dot phrase and fill in the blanks, and that's a standardized version that goes on to the patient's interdisciplinary note, so everybody knows what to do and what to expect for that patient. And most of all, patients who have multiple risk factors, there is a need for longer term follow-up. These are patients who go through pregnancy fine, they do well, but they may present, like I said, with cardiomyopathy 2 or 3 months later. What do we do then? And what are the different ways to follow them in that period? This is a cardio-OB team at UCI. We have maternal fetal medicine, obstetricians, myself, Dr. Steller, Dr. Post. We have cardiology colleagues, Dr. Gashki, Kim, Pislow, Deneen, Jeanette Lynn. So we have a congenital heart disease specialist in there. We have an imaging specialist, and we have a general cardiologist on. And likewise, from the anesthesia side, we have OB anesthesia, we have cardiothoracic anesthesia, we also have cardiothoracic surgeon who is involved or to go-to person for our multidisciplinary meetings as needed. We have had several patients that we have taken care of in a cardiovascular or cardiothoracic OR, where we have the ECMO team, we have the perfusionist, and we have all of those team members in there, where we deliver the patient and then the team takes over. A recent patient that 2 weeks ago we delivered in the main OR. This is a patient who is hypoplastic left heart syndrome, who had a Fontan with somewhat compromised systemic ventricle. Overall doing well, but on top of that, this was her third delivery that we were doing, and she has 2 prior C-sections. This time around, she also had placenta accreta. So it was a very complicated decision-making and planning. And it was interesting that this patient had a prior preterm delivery at 28 weeks. This time she had ruptured her bag of water, so she had PPROM at 24 weeks. And normally from obstetrical, those of you who are obstetricians, we know that we admit these patients right when they rupture until they deliver. So this is one patient, and it's interesting when you're taking care of patients with congenital heart disease or patients who have gone through medical, lot of interactions with medical system. They are different. They are they have their own way of dealing with certain situations. So there was no way she would be convinced to stay in the hospital. She actually left the hospital, and we had modified her care so that we were bringing her every day for an NST, making sure baby's okay. And finally, she agreed to having her C-section and cesarean hysterectomy at 32 weeks. And that is when we took her to the OR with the whole team. And fortunately, everything went very well. But it presents a dilemma, and particularly in situations where you want all of the teams to be there at the time of delivery and the coordination that it takes to do that. Unless you have an ongoing working relationship with all of the team members, it becomes really hard. So I'm sure you do have it here. It's a great heart institute, and I'm sure there's a lot of patients that you take care of routinely. In this last few years I would say from 6 or 7 years, last 6, 7 years, there's a lot of publications in the cardio-obstetrics space. I used to have a slide that I don't have it here right now, where I would show a cardiologist office, just a cardiology office. And it would say, the sign over there would say, no pregnant patients allowed. And then the next slide would be obstetrician's office, and it would say, no cardiac patients allowed. We have come a long ways from there. I think I'm so proud and inspired by the work that is being done everywhere. In each state, there's many teams, individuals who are dedicated to improving care. And this is one example, one publication for Dr. Davis. And again, highlighting the cardio-obstetrics model of care. I think this is time where there's a lot of interest from the cardiology fellows to learn about pregnant patients. As you know, in the last 4 years, I had started this cardio-OB case reviews, FIT case review, fellow in training case reviews, there was a lot of interest. So over the last 3 or 4 years, these quarterly case reviews or the attendance became so large that I spoke to SMFM, the Society of Maternal Fetal Medicine. They actually took this over. So October will be the first time it'll be sponsored through SMFM. And there are over 300 participants registered already. All we do is we have one of the institutions, and you may decide to present your case next time. If you go to smfm.org, and there's a there are these cardio-obstetrics case. So if there's an interesting case that you have here, you could go in and register your case, and there will be a discussion with many cardio-OB, especially from the cardiology side in care of these patients. And there's a big participation, a lot of learning there. So the cardio-OB team, for the patient, again, you need to have the specialists lined up together to take care of those patients. And likewise, a lot of times you'll come across a cardiac condition where it's not clear, it's not a low risk, it's not a high risk where you absolutely say that you cannot get pregnant or pregnancy termination is required. But a lot of these cases are somewhere in the middle. And then that brings up the shared decision making, the patient's participation in their own medical care, and come up with a plan that you're going to have to care for them. So with that, I hope by this time we understand that cardiovascular disease is the #1 cause of maternal mortality. Why is it not recognized? Because there's such an overlap between pregnancy and cardiovascular symptoms, because of pregnancy being on the treadmill for 9 months. And the only way really to improve is to have that index of suspicion, to have some sort of a risk assessment algorithm, tool, a way to stratify patients, and those who are at high risk to follow them appropriately, those who have pre-existing cardiovascular disease, again, help them stratify, have them deliver at the place that they will require the care. And then at any place where any maternity unit, there needs to be identified members of the team. There needs to be some sort of a team. It doesn't mean that, if your resources allow you to just have 3 specialties there. It's anesthesia, general OB, and maybe a primary care. That could be the cardio-OB team. But the most important thing is to have individuals, physicians, healthcare providers that are interested, and they are committed to taking care of this group of patients. With that, I'm going to stop there. We do have a website. You could actually, if there's any questions, we have all the publications, the work, the implementation guide, cardiovascular risk assessment, all on the website, and our group continually updates it. So feel free to reach out if you have any questions at all. I'd be happy to take that. Thank you very much.
All right, thanks. Thank you so much, Dr. Hameed. As you guys know, we do have our own cardio-obstetrics program here. This is led by Dr. Laura DeVoki. Unfortunately, she had a family issue she had to deal with and couldn't be here this morning. Having stated that, we have Savannah Sanders, she's one of our nurse practitioners and has been in the cardio-obstetric space now for the last 2 years, probably. So she's going to give a quick overview of our program here and give us some insight, and then we'll piggyback with some questions shortly. Thanks.
Hello, my name is Savannah. I am the physician assistant at the Women's Heart Center here at GHI. That's going to be a very difficult presentation to follow up on. She did such a great job, but I am excited to just give you an update about what we're doing here at Northeast Georgia. And we've based a lot of it off of what they've done in California. So it's really exciting to see the things that she's discussing and the things that we have been able to implement here. Just as brief background information, in case y'all are not aware, we do have a grant that was given to Northeast Georgia to improve maternal mortality across all of the state of Georgia, with just one focus in cardiology. There's other areas that grant is also going towards, but since it's here, we are able to start that process here and be able to share it with other institutions across the state. So just like she was discussing, we do have a CVD risk assessment. We started this CVD risk assessment on paper back in 2023 of August. We screened for a little while, was able to get this up into Epic, we now are screening on all 3 campuses. So Gainesville, Brazelton, and Habersham. We are screening patients who are admitted onto antepartum and on day 1 after delivery. Our goal is to help moms be screened on the outpatient offices, and even when they go to the ER. We're not quite at that process yet, but we have a meeting this month, next month, one of the two, where we're going to discuss getting this screening tool put in the outpatient settings so that we can screen patients more than just at the end of their pregnancy. When a patient does screen positive, just as she has shared, we have a BPA/order set that appears when a patient screens positive. This is a nursing protocol. So the nurses put in this order set. It is a consult to the inpatient cardiology team, which is me, and all the general cardiologists who round. So thanks for all the help that they put in. They also get an NT-proBNP and an EKG. Part of our process is exactly that. We're screening patients. They're getting that NT-Pro, they're getting that consult. Sometimes the consult isn't always necessary. And what I mean by necessary is the patient is ready to go home, the baby's ready to go home, she's very ready to go home and sleep in her bed, and she just is having, a little bit of shortness of breath, and then she has risk factors. So she feels okay, but she wants to go home and doesn't really want to wait for that consult. In those situations, we will put in an outpatient consult and see the patient shortly after delivery. So they're still getting in with cardiology, even if it's not an inpatient consult. Whenever they do get that inpatient consult, or outpatient consult, we do have a pharmacist who works with us who helps that patient throughout either the pregnancy if they were screened on antepartum, or after delivery when they're breastfeeding, talking about smoking cessation, blood pressure management, all of those things to help the patient understand what medications they need to be on during pregnancy, during breastfeeding. Is it safe? What side effects? All of that can be very cumbersome, and grateful that we have a pharmacist here who, if you have any questions regarding cardiac medications or anything with pregnancy, she's a resource to everyone. I just like to hoard her. Next is all of our patients who do screen positive, we give them a peach card. This is something that was released by the Georgia Perinatal Quality Collaborative, and it's just basically warning signs saying, hey, you did screen positive. We know that moms are at risk for a full year after delivery. So, we did the EKG, we did the NT-Pro, we did the echo. I think everything's okay right now, but I'm going to give you this. And if you were to have worsening of any of these symptoms or development of any of these symptoms, I need you to reach out to your OB, primary care, someone, so that these can be evaluated and that they are not ignored. I do want to tell you more about just the screening process that we've done here. So again, we started that paper CVD screening in Brazelton in August of 2023. We were able to successfully integrate it into Epic in both the Brazelton and Gainesville locations in December of 2023. And then we recently were able to get Habersham in the Epic screening back in June of this year. Since that time period, we have screened a total of 3,697 patients. Of those, there were 117 positive screens. So we, as a Northeast Georgia health system, have about a 3% positivity rate. We do see that fluctuate a little bit. We've seen it between 2 and 3 for the most part, though. I did want to just share kind of what is making patients positive. So 27% of patients had a yes in each category, meaning they had one symptom, They had one vital sign and they had one risk factor, meaning they are now positive. 28% had a red flag. So they're the same red flags that she shared with us. The blood pressure is greater than 160, or their O2 status below 93, etc. Sleeping on 4 pillows due to shortness of breath. 36% are physical exam findings. I will tell you that the physical exam findings that are most commonly acknowledged are heart murmurs. These are often heard by our nurses, and some of this may be a little bit higher because at the beginning we were getting a lot of consults for murmurs, even if the patient had it prior to. So definitely the murmurs are one of our physical exam findings that we see the most. And then 53% of patients had 4 in any category. That means they had 4 things that were in any combination. They could have been risk factors, physical exams, symptoms, anything. Of our 117 patients who screened positive, 110 of those were actually seen by a cardiologist. So some of that gap in there could be because at the beginning there was definitely some workflow concerns about making sure communication was clear that cardiology did need to come see them. And then of course for some of those patients who we didn't quite see them inpatient and said, hey, we do, this is important. We do want to see you outpatient. Sometimes that follow-up isn't there. For the short period of time, I won't break down each of those scenarios. I will say that we are doing research just of how the hospital system feels this is going. We've asked nurses and providers and things, and overall, the feedback has been great. They really have enjoyed the process. Feels like that, this has been embraced since it is a very new thing. Anytime you do something new, everybody gets really scared. But it seems to have great feedback, and we're happy to be able to take the hard work that was done in California and be able to bring it here to just the small town of Northeast Georgia and to help our community. And now we're able to take what we're doing here in our community and share it across the state. So if anyone has any questions about what we're doing here at Northeast Georgia, if you have questions about kind of our team, if you want to be involved, anything like that, please, please, please reach out to myself, to Dr. DeVokie, to anyone, and they'll guide you to me, because we love to share more about what we're doing to make improvements, if you have recommendations for improvements. But I won't take much more of your time. I think they're wanting to give an opportunity for questions.
Thanks so much, Savannah, for that wonderful update. And hopefully folks who were not aware earlier now, perhaps you've seen the program that's available, and please do reach out to Savannah and her team. And I've found them to be quite phenomenal because we've had a few patients who's come in and we've been able to co-manage and also take really good care of the patients. The one thing I'll add, because we do have a cardiovascular disease fellowship program here, roughly 18 fellows, and we've done simulations in the lab with cardio-obstetrics patients in our sim lab where patients come in and mimic. We have some high fives back there. Have come in and mimicked pregnant women with cardiovascular symptoms, and our fellows have gone through that process and sort of thought about it. So I think it's important to kind of highlight that we have learners who are kind of getting the skill set as we go forward. Having said that, I'm going to open it up to questions. We can see if there's any questions in the audience or comments or any questions online.
If you have any questions, here we go. We have a question from Holly.
All right, excellent.
Coming to you.
Thank you, Dr. Hameed, for an outstanding talk, and thank you for being here today and for all the work that you've done. My question is around more sort of the prevention side. In terms of what you and your practice and your clinic do, we've noted that the incidence of cardiovascular disease among young adults in the United States is increasing. So are you seeing the same increases from a prevention standpoint? How do you intervene with patients prior to pregnancy to help prevent cardiovascular disease from worsening during and after pregnancy?
Thank you for the great question. Before I answer your question, I'm so proud of you. I'm so happy to know what you are doing. And honestly, I think this is the work that we have to collaborate and put together and make it more impactful. We are on the other side. We're in California. And the work is phenomenal. So congratulations. Really happy to see that. So going back to your question, I think this is not just about the screening in one time frame, that 2 minutes and you're done, right? It's about preventing. It's about preconception. So a lot of, as soon as the patient has that interaction with healthcare, a lot of times young people, the first time they ever see a provider is when they're pregnant. That may be the only touch point in the healthcare system, which makes it even more important, right? So any risk factors that need to be modified in a cardiology practice, primary care practice, it applies to those young people as well. So I think if we all bring that awareness, at the time we are seeing more patients when they do get pregnant, but if they come in for preconception counseling for any reason and they have risk factors, or you identify risk factors and you have an opportunity for interconception care in the future pregnancy, I think that's where all of those preventive measures will come in. And that could be, and again, it needs to be studied. For we know that in a group setting, in a peer review setting, people tend to do better. So this could be focus groups. This could be support group for patients who have high blood pressure or screen positive risk for CVD, for example, and empower them in such a way that they make positive change in their lives.
So we know that the largest population that is underserved here are Black women. So, and then a lot of those people are somewhat lower economic situations and those kinds of things. How do you fix that gap with, they're 3 months out, they really do need to be followed up, but they don't have insurance, those kinds of issues?
I think you bring up, again, a very important point. And when I brought up earlier the fact that we had submitted this as a measure, CVD screening for all pregnant patients, one of the biggest gaps and what we have to cover is exactly what you are referring to. There was a concern that if you mandate cardiovascular screening in all care settings, what happens to that situation you just brought up? How do we get to, for example, the maternity deserts? Where do we go when there is a low resource setting? And we have work to do. I think, one of the good things that came out of COVID pandemic and the use of telemedicine and the use of Zoom and remote care is one thing that was positive that we have all learned. So I think we need to establish ways to provide access to patients. The extended insurance coverage after the patients deliver, not end at that postpartum week 8, but continue through the rest of the year. And then have some sort of, again, it'll be individualized to each care setting. It could be a telemedicine, a phone call, a nurse visit, is some sort of a touch point with healthcare that would, again, give an opportunity to this patient to be part of a preventative plan or have a direction which way to go if they have symptoms or have, So in other words, we have to build a process that would connect that patient that is remote from the mainstream academic or a big institution. How do they get to that if needed? And we have to work on that. I don't have an answer at the moment. I know that the pregnancy care or the insurance has extended beyond the conventional postpartum period, but we have to find ways to connect the patient back to the healthcare system.
I just want to add on to that, specifically here in Georgia, and somebody who works in a different OB area might be able to speak better. But we do have, when a patient comes into our hospital system or our OB offices, you know, they're 3 months pregnant and they don't have insurance, we help them with that process, make sure that they get the paperwork that they need to be able to apply. We can't do it for them, but we can give them the resources to do it. And if I'm not mistaken, Georgia has extended that coverage for a full year after delivery. So we've already met, you know, a few of those issues. Of course, getting a mom in here, you know, after delivery, getting them in here definitely is difficult, just as she was saying, adding on to, you know, capitalize on telehealth visits, things like that. But as far as the insurance and the coverage for the full year, we do have that win
Oh,
here.
that's great. Good to know. So I think since it's relatively new, I think we have to create those processes, right? For each of these patients who delivers, particularly high-risk ones, to stay connected up to a year. So at least, you know, in that period, not only you'd improve their metabolic or cardiovascular profile, but also get them at a better health situation for their next pregnancy.
Thank you. And we do have one question online. I guess this will need to be our last question for the day. It's a two-part question. Is there any engagement feedback loop that includes feedback from patients on impact of the process? And how much do you document, including, I have to rephrase this. How much do you document, include support, persons, documentation, observation of the CVD history, for example, symptomology? Let me know if you need me to reread that. So the first question, is there any engagement feedback loop?
Yes. So what we have during this whole process, first of all, we have this technical expert panel where we have lived experience people on there. We have patients who are part of it and so on. So we get input when we have formulated all of the work we have done. On top of that, of the patients who screen positive, we actually have a manuscript out for publication. And it's mainly to evaluate their perception of the whole process. And we have included some of the comments, the patient interviews. So we have 40 or 45 interviews already from New York, from California, from Tennessee. It's going to be published soon. But in general, patients actually welcomed this. A lot of patients were positively engaged in the sense that they felt, oh, so somebody finally, you know, we are getting attention, or I am being told that I may be at risk, and I've already changed this, this, and this in my life. So all of those, you know, in an organized way, again, is submitted for publication. That's a very important point because we are, after all, this is all being done to improve patient care, and we need to hear their voices as to what their input is in the process. And it's been very positive so far.
Thank you very much.
Thank you.
All right. Thanks so much again for that excellent discussion. Thanks everyone for attending. Please reach out to us if there's any questions or comments that come up, and we will send out the next announcement for upcoming ground rounds next month. Thank you so much. Bye-bye.
Thank you.